Oral Health Assessment Tool, or OHAT, Series 3. Ideally, all residents in long-term care should have a complete oral health examination by a qualified dental professional upon admission and then on a regular basis thereafter. Best practice indicates that these examinations should be supplemented with oral health assessments and screenings by trained caregivers. The only published comprehensive oral health assessment tool developed specifically for use by caregivers for residents in residential care was the Kaiser-Jones Brief Oral Health Status Examination, which was first published in 1995. Further trialing of this tool was undertaken by Dr. Jane Chalmers in 2003, which resulted in some modifications to the tool, which Dr. Chalmers then renamed the Oral Health Assessment Tool, or OHAT. In 2007, with permission from Dr. Chalmers, the OHAT was modified slightly to meet the needs of long-term care homes in the regional municipality of Halton. This tool was featured in the RNAO Nursing Best Practice Guideline Oral Health Nursing Assessment and Interventions 2008. In Ontario, long-term care assessments are to be conducted upon admission and then quarterly, so this section was added to the top of the OHAT. The categories include, on the left, lips, tongue, gums and tissues, saliva, natural teeth, dentures, oral cleanliness, and denture pain. Each of the categories have been given a code: 0 for healthy, 1 is a level of change, and 2 is an unhealthy change. What's interesting with the OHAT tool is it's been color-coded so that the follow-up actions are clearly presented, so that when the assessor is doing the assessment, they have some sense of what needs to be referred or what intervention they can do or provide in the meantime. The action required, action completed columns were added to support accountability. At the bottom, there was also a follow-up section incorporated in order to complete the case management component. A comparison of the OHAT to the Resident Assessment Instrument Minimum Dataset, or RIMDS, shows that many of the categories that are in the RIMDS are covered in the OHAT, but in fact the OHAT has significantly more categories. We suggest that you do the OHAT, then add the outcome information into the MDS-RI. We'll now go through each of the categories independently. Lips. Healthy lips should be continuous in color, firm in texture, free of lesions, semi-moist, with an apparent border between the lips and the skin of the face. The commissures or corners of the mouth should be continuous and intact. A level 1 change would include things like lip dryness, cracks and irritation, angular cheilitis, which is inflammation in the fissures at the corners of the mouth, herpes simplex lesions. These are findings that can be treated using in-house protocols. Level 2 or unhealthy are abnormal findings that are serious in nature and require immediate referral for further investigation. They would include things like skin changes, as shown in the slide on the far right. The oral care interventions or actions required would include things like the use of lanolin or KY jelly or other lip lubricants. Do not use petroleum-based products. In the case of the angular cheilitis or the cracking at the corners of the mouth, consider the possibility of a vitamin B deficiency. In other words, looking at their diets, looking at the use of grains and cereals. You want to monitor any of these conditions for 7 days and then refer if there is no change. An example of monitoring outcome would be angular cheilitis, which can be accompanied by Candida albicans or yeast or thrust infection. So you want to monitor for any changes, because if it doesn't clear up, it's likely to be a Candida infection. Therefore, you have to make a referral to the physician. Tongue. A healthy tongue shows bilateral symmetry. It's reddish pink all over and very moist. It may be pigmented in relation to the normal coloration of the skin. Level 1 changes would include things like redness due to xerostomia or dry mouth, or varicosities. You'll see that in this picture there's a small blue spot on the lower part of the tongue in this middle photo. Other changes could include things like fissured tongue, which is clefts or narrow slits that are visible on the surface of the tongue, or geographic tongue. These are areas that are void or denuded of papilla that appear over time to migrate due to ongoing degeneration and regeneration of the papilla on the tongue surface. It could be light or uneven coating of the tongue. In fact, this photo shows half the tongue is coated, which is a sign that it may be due to a stroke. Some are related to aging or medical conditions. Although not normal, they do need to be monitored. Level 2 or unhealthy changes would include extreme coating, such as shown in the photo in the far right, tenderness, extreme color changes, enlargement, or difficulty swallowing. The oral care intervention action required would be cleaning the tongue twice daily with a soft toothbrush or tooth scraper. Cleaning the tongue is as important as cleaning the teeth, but more likely to stimulate the gag reflex. Just a tip, you can place the toothbrush across the tongue and ask the resident to press their tongue against the brush and move it in and out of their mouth. This sometimes tricks that gag reflex as it puts the tongue in control of movement. In any case, you do want to monitor for changes and refer if there is no change after 7 days. Gums and tissues. Healthy gums and tissues should be a continuous pinkish red color or pigmented in relation to the normal coloration of the client's skin, firm in texture, free of lesions, and moist. Level 1 changes, the most notable changes would be in gums and tissues, and they will require some referral, but mild changes may respond to simple in-house treatment and monitoring. So this area might become a judgment call. Level 1 changes might include things like abrasions, traumatic lesions, a light buildup of soft debris, mild redness in the gum tissue. These things could be treated and monitored. Obvious decay in up to 6 teeth or broken teeth, though, would require referral, as would a sore under a denture. And level 2, unhealthy or abnormal findings include things like obvious decay in 7 or more teeth, abundant amounts of debris, excessive bleeding, and halitosis. The oral care intervention or action required. You want to continue brushing teeth, gums, and tissues of the mouth with a soft toothbrush twice a day. Brushing teeth, gums, and tissues of the mouth is an essential first step to improving oral health. You want to monitor your bleeding gums and refer if no improvement is visible within 7 to 10 days. Usually, if it's simply something to do with debris in the mouth, general gingivitis, you will see improvement in tissues easily and quickly within 7 to 10 days if you implement the twice-a-day toothbrushing regime. Saliva. The majority of saliva in the mouth is secreted from the parotid salivary gland through ducts in the cheeks called Stenson's ducts, and the submandibular salivary gland through sublingual ducts, which are located under the tongue. Salivary flow is controlled by the autonomic nervous system. The smell of food or just the presence of something in the mouth will start the glands secreting. There are a number of medications that can cause over or understimulation of these glands, so checking medications will help understand why there may be more or less saliva in a client's mouth. Normal amounts of saliva vary considerably from one individual to another. Healthy mouths are moist and saliva can be readily observed pooling beneath the tongue. When looking at level 1 changes, remember that habits such as mouth breathing, alcohol use, smoking, and/or chewing tobacco can result in changes to the moisture levels in the mouth. Tissues that are dry and sticky with little saliva present can first be treated in-house and then monitored. Level 2 or unhealthy conditions such as parched, very red tissues with little evidence of saliva require referral for further investigation. Residents or clients will often complain of having a dry mouth and frequently suck on candies, leading to root and tooth decay, and/or they may rinse with mouthwash to try to relieve the dryness. These symptoms can be exacerbated if there's alcohol in the mouthwash. The oral care intervention or action required. Brushing teeth, gums, and tissues of the mouth is the essential first step to improving anyone's oral health. You may want to check for medications that may be causing dry mouth. You can implement the use of dry mouth products. Some samples are shown on the screen, but they are not the only ones that are available. You want to focus on increasing the resident's fluid intake. Improvement in tissues will usually be seen with 7 to 10 days. So you want to continue to monitor, and if no improvement is noticed within that time frame, you will want to likely refer. Natural teeth can be assumed to be healthy when there's no decay, no broken teeth. Please note, though, that old silver or amalgam fillings can sometimes be quite black looking. This is not to be confused with tooth decay. Level 1 or 2 changes will always result in a referral. Your oral care intervention. Again, brushing twice daily or more, depending on the type of issue that you're dealing with. Always brush teeth and oral tissues with a soft toothbrush. Level 1 and level 2 changes will require a referral to a dentist. Again, you want to continue to monitor. Dentures. Careful inspection of dentures is required. Complete or full dentures should be fully intact all around the borders. No cracks or breaks should be visible in the pink acrylic surfaces. The teeth should all be intact and the denture should be identified. Surfaces should be clean and free of tartar and debris. Partial dentures will usually have one or more metal clasps. These clasps should be inspected closely to ensure that they are intact. The partial denture should be inspected first in the mouth and then again once it's removed. All areas should be intact and the partial should be identified. Surfaces should be clean and free of tartar and debris. Level 1 change would be recorded if there's one chipped or broken or cracked area, a broken clasp, or possibly a broken tooth. If there's no name on the denture, or the resident only wears the denture for 1 or 2 hours daily. If there's a small amount of tartar or soft debris. In-house treatment can be initiated as appropriate. Referral is generally not necessary unless there is concern expressed by the resident or the assessor feels the situation poses a risk. Level 2 or unhealthy category covers situations where there is more than one broken area or broken tooth. The denture is maybe split in 2 pieces, it's not worn due to poor fit or causing discomfort. The denture maybe can only be worn if denture adhesive is used. The denture may be covered with heavy tartar, stain, or debris that cannot be removed by staff. Generally, your oral care intervention will include identifying the denture. For acrylic dentures, you can implement a half white vinegar, half water soak to help loosen some of the hard deposits. The identification kits are readily available, easy for staff to use. Generally, these kits include a sanding sponge, a marking pencil, and acrylic sealer. For full or complete dentures that have a minor amount of hard tartar, you can implement a weekly overnight vinegar soak, as I mentioned earlier, half white vinegar, half water. Dentures also need to be brushed with a denture brush and water or denture cleaning paste twice daily to remove soft debris. Simply soaking a denture will not remove soft, sticky plaque. Assessing oral cleanliness is relatively straightforward. Healthy mouths are clean with no food particles or hard deposits visible. Level 1 changes would be indicated if there's a small amount of visible debris and possibly tartar in one or two areas of the mouth. But the assessor feels that implementing better oral hygiene care will most likely reverse the situation. Level 2 would be recorded where there are food particles, heavy tartar, and debris in most areas of the mouth, severe halitosis, or the assessor feels that cleaning by a dental professional is going to be required. The oral care intervention or action will be brushing the teeth and oral tissues twice daily with a soft brush and monitoring the levels of plaque and debris. Implementing proper cleaning should result in a visible improvement within 7 to 10 days. The tip-off is usually bleeding. With proper oral care, there should be no visible bleeding when you're brushing teeth. If proper care is implemented and bleeding continues after 10 days, then referral will be advised. Dental pain often goes unrecognized, particularly if a resident is unable to communicate verbally. Careful monitoring is essential. If there is no behavioral, verbal, or physical sign of pain exhibited, then the resident can be deemed to be healthy. For level 1 or 2 categories, referral is always advised. A level 1 category would be recorded where a resident is agitated, resists oral care, exhibits verbal and/or behavioral signs of pain such as pulling at the face, chewing lips, refusing to eat, and even aggressive behavior. A level 2 category would be recorded where there are physical signs such as swelling or cheek or gum, broken teeth, ulcers, abscess, as well as verbal and/or behavioral signs. In terms of oral care intervention, referral is necessary for either level 1 or level 2. Antibiotic, antifungal, or other medication may be required. In all instances, though, staff should continue with daily oral care as outlined. The action completed section. This section serves as a reminder to ensure that either the nursing intervention took place or a referral was made. If a no is checked off, then an explanation and further documentation should be made. In terms of follow-up, an oral hygiene care plan should be completed for each resident. The follow-up assessment could be quarterly or sooner if the condition is being monitored. And remember to review and update the oral hygiene care plan after each new assessment. The oral hygiene care plan, this is a sample of a care plan which can help provide helpful individual information about each resident. It can be posted in the resident's bathroom as well as included in the chart. The top left corner can be completed using information that is collected from the OHAT. In the lower portion, outlining barriers should be completed with input from the caregivers who work regularly with this client or resident. The top right section will require input from a dental professional or a caregiver with some dental training. In terms of follow-up, if the resident or the family or guardian refuses referral and/or dental treatment, this should be recorded. This will complete the whole case management process. For additional resources, please check some of the following websites that are contained in the next few slides and the articles that are available. Thank you.